Very good afternoon to all of you. Yeah, and it's always a pleasure to come back to Lucknow. I think I was hearing my friends Tribhuvan and Abhishek talking, so it's always a pleasure. So, yeah. So, is my slides visible?
Yes. Please go ahead.
So, we'll start with the EEG waveforms. I think the most important or the most curious or the most interesting part whenever we come across the EEGs in our ward rounds. I mean, all our residents, the PGs, everyone ask for कि सर इसमें क्या दिख रहा है, waveforms में क्या दिख रहा है, कहाँ पे abnormalities हैं, हमारा प्लान हमारा माइंड हमेशा abnormalities की तरफ में जाता है, कहाँ पे चीजें abnormal दिख रही है, कहाँ स्पाइक्स दिख रहा है. But before we start picking up the abnormalities, before we start picking up the abnormal waves, it's very wise to know what is normal in an EEG graph. I mean, as for any other modality, because once you know the normal, it becomes easier to pick up what is something which is different from the normal and which is maybe an abnormal thing. So very rightly said, EEG is a kind of like a personal handwriting. You need to see it a number of times so that you can start deciphering it in a way. And sometimes you'll find that even the EEG machines at different places may have some amount of artifacts, like our institution or some other institutions. You start finding some amount of different artifacts as per the EEG's pattern. And you understand that from my instrument, this thing comes, which looks most likely a kind of like artifact on the part. So we saw yesterday by Dr. Goswami how the EEG waveforms are generated from the brain part. What we'll be seeing today onwards, that what do we look in the EEG waveforms. So this is the first thing. So when you see an EEG graph, like this is an EEG graph, almost around 8-9-year-old child. So what you see, these two yellow lines are 1 second. So this is 1 second, this is 1 second, this is 1 second, this is 1 second. So when you talk about the waveforms, you talk about the waveforms in their frequency, how frequent the waveforms are coming in terms of their morphology and in terms of their spread and the nature also. So frequency is how many waves are occurring per second. So if you count, this is the 1 second part in this EEG, which is a bipolar montage, and we're looking at frontal to occipital location. So if you count in this location at the occipit part, the waveforms will be something around 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So almost 10 waveforms. So this is like a 10 per second waveform, so which falls into the alpha category of the waveform. And this is one complete wave. One upstroke, downstroke is one complete wave. So you have got 10 per second, which falls into the alpha part. If you count anteriorly in the, the frontal location, you can't count because there are so many waveforms, small, tiny waveforms. Definitely they will be falling into the beta category on the part, similarly in this location. So this is about the first thing which you look in the EEG waveforms, that how many waves are occurring per second, to call in terms of the frequency on the part. Because based on the frequency, you divide the EEG waves, either they are in the alpha range when they are in the range of 8 to 13 hertz, just now we saw, or they are in the beta range, we saw in the frontal eye fields when they are more than 13 hertz, or they are slower waves like theta wave, which is 4 to 7 hertz, and delta, which is less than 4 hertz. So less than 4 waves per second will be the delta waves. So these are the 4 basics of waveforms in terms of their frequency, and these waveforms we'll see subsequently are seen at different locations on the scalp and in different stages of your wakefulness and sleep. But you have to understand that these alpha waves are normally seen in wakefulness, but if it is being seen during sleep also, that may become abnormal. So like similarly, theta waves or delta waves are mostly seen during the sleep phase. But if you're finding it during the wakefulness, that may be abnormal. So that is why recognizing the waves, this is finding in the which range and in which state will tell you this is a normal wave or this is an abnormal wave on that part. most often you'll find that you get a mixture of waves. You don't get a very clear alpha waves, beta waves, or theta waves. What you get is basically mixture waves, like what you see in this EEG. They have got like, this is 1 second from this line to this line, and this is one wave, and this is one up stroke, down stroke. This is complete one wave, and maybe this is the half wave. This falls into the delta range because this is less than 4 hertz. But if you look at this part, what you find that on top of these waves, there are small waves also, like these ones, maybe better seen in this location, these small waves, which is over the slower waves. So what we call this is mixture of frequency. This is predominantly delta wave with superimposed beta activities, which we can see in a child who is comatose and is receiving midazolam infusion or those kinds of drugs because of the parts. So this is superimposed beta over the delta wave mixture of frequencies on the part. Second, what we see is the amplitude of the wave. So that means how high is the wave. Normally you find that the waves amplitude are between 10 to 50 microvolts in the human brain. So you measure from the base to the peak of a wave to measure it, and all the EEG machines have got now the amplitude measurement indicator by which you can measure the amplitudes. Because if the amplitudes are high, like what we see in cases of hips arrhythmias, chaotic high amplitude waves, or amplitude may be low, what we see in cases of even hip electrode decrement or burst suppression pattern, suppression of background activities, or in encephalitis pattern basically. So knowing the amplitude will be important, that the EEG is normal or for the abnormal part. Then comes the morphology of the waves. So as I said to you, one wave constitutes of one upstroke and then one downstroke. And if it is not crossing the midline once, it is monophagic waves. If it is crossing the baseline again and then coming up, it is the biphagic waves. If it is crossing the baseline a number of times, it becomes a polyphagic waves. So normally like a spike and waves are like these ones. So like they have got one spike and then they go down and they come up. So this is called a spike and wave kind of pattern, which my Dr. Chandrakanta will be talking about more about these kinds of patterns. But this is the morphology of the wave. Normally we expect waves like monophagic waves. These may be abnormal, the biphagic and the polyphagic waves on the part. Then similarly in the morphology, you can have the monomorphic waves. Like all the waves are of the similar amplitude and frequency. Like you see in this one, this is 1 second and you see almost one, maybe two waves. And so similar in frequency, 2 hertz, two waves per second. And morphology also, they are of the similar amplitude. So this is called as the monomorphic waves, which can be an indicative of abnormalities, seizures, or sometimes they can be polymorphic, so of different morphology, like amplitude and the frequency. Like here it is of different frequency, and here it is of different frequency, or here it is of different frequency in these ways. This is a polymorphic waves on the part. So this is about the EEG waveforms. So you locate about the, you know about the EEG, the different waveforms in terms of their frequency, alpha, beta, theta, delta, in terms of their amplitude, 10 to 50 microvolt is the normal range, and in terms of their morphology, they are monophagic, biphagic, or polyphagic part. So now comes the EEG waveforms. When we see these EEG, these waveforms, as I mentioned to you, have to be seen in 3 clinical contexts basically. The first in the form of age, because age has got a lot of variations in the waveforms, their frequency, their morphology. Second, the older you become, your waveforms are much more on the slower side. Second, and more important, is your state. If you are in sleep phase, as I mentioned to you, where waves become much more slower, you go in the theta and delta range. If you are awake, you should be more in the alpha range, especially more than 3 years of age, you should be doing the right range. So stage, knowing the stage is very, very important. Normally technicians mentions about the part that now the sleep has started, it is wakefulness on the part. And waveforms also changes with the activation procedures. We'll talk about the part, the hyperventilation and the photic stimulations. So when you see the EEG waveforms, you've got 2 ways to see these EEGs, I mean waveforms on a part. Either you see you make a mental list of your elements, like you know from the history, from the requisition, this is a 10-year-old child, apparently healthy child, and I'm going to see an EEG which has got both awake and sleep record. So it means that you got a mental picture of a 10-year-old child in wakefulness. You are going to see the, as we discussed about the alpha waves in the posteriorly, and when you go into sleep, you're going to see more of a slower waves, the theta delta waves, along with the sleep features. So you go with a mental picture that this I'm going to see, and if I'm finding anything missing or anything extra, then it may be something which has to be looked for. That is one way of looking at the EEG part. The second way is this, that you start looking at the pages and you find that what I'm seeing. So like I'm seeing this theta waves on this page, but is this child awake? No, he's sleeping. It means this is abnormal. So you see the waves and then you take a call. I'm seeing the alpha waves, but the child is sleeping. It means this is abnormal. This can be an alpha coma in the way. So that is the other way of reading the EEG's part, and you can combine the things, both the things together. So like as you mature in your EEG reading, it becomes automatic, and you start combining both the things together. So you you write the EEG, you order an EEG, and you know that what I'm looking for in this child, a child with the non-epileptic events. You see the EEG can be normal. A child with the childhood absence epilepsy, you know that I'll be getting the hyperventilation, 3 hertz spike and wave kind of pattern. So you go with a mental picture, but you keep on looking at each and every pages on the part. So this is the part. So now look at this EEG. This is an EEG of almost around 10-year-old child. And if I look at this, and this is an anteroposterior longitudinal Mond chart, this is the left part of the brain, because this is FT1, F7, F7T3. We discussed yesterday about the odd numbers representing the left part of the brain, and this is the right part of the brain in blue, because this is FP2, F4, F8, T4, T4, T6, and T6O2. So this is left part, this is right, this is left, this is right, and this is bipolar montage. So what we are seeing is this is the anteroposterior, because this is frontopolar, and this is temporo-occipital. So what you are seeing, that this is an awake 10-year-old child. So I know from looking at this a couple of slides before, that awake 10-year-old child should have an alpha rhythm in the background. Background means normally we look at the background either grossly or in the posterior location. So look at this part. You get 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Fine. So this is almost in the alpha range. So this is awake 10-year-old child. The waveforms appear to be normal. And what you see, I'll just say, this is called as antero-posterior gradient. When you see an awake child, wakefulness, that means anteriorly the waveforms are faster. You can't calculate also, but they are smaller in amplitude. Posteriorly, the waveforms are slower. You can count, but they are larger in amplitude. This is an antero-posterior gradient, which is a normal finding. It should be there in an EEG part. So alpha rhythm, well developed by 8 years of the age. Frequency increases with the age. 8 to 13 hertz. Occipital location, just now we saw on the previous EEG. It appears in relaxed wakefulness, disappears when you open the eyes. So when the eyes are closed and you are awake, you see the alpha rhythm. If the eyes are open and you are awake, alpha rhythm goes off. Normally by 3 years onwards, you must get off 8 hertz per second. Below 3 years, you may have lower frequency of the posterior dominant rhythm. They may not be in the alpha range in that sense, but beyond 3 years of the age, you should start getting the 8 hertz and above the posterior dominant rhythm. So posterior dominant rhythm is the rhythm which you see in the occipit. Visually, this is in the alpha range. That's why we call them as the alpha rhythm, but it may not be in the alpha range, especially if you're seeing a child of 1 year. It can be normal. But if you're looking at a child of 8 years and you're finding a waveform in the posterior of 5 hertz, that is something which is maybe abnormal on that side. So we talked about the anterior posterior gradient over the part. So now look at this EEG. So what we saw about the alpha rhythm or posterior dominant rhythm, the rhythm which is dominant in the posterior location and which is found in the wakefulness with the eyes open. So look at this part, P3O1, left part of the brain, and you count this is 1 second, and you count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. This is 10 hertz, and this is the alpha rhythm, posterior dominant rhythm. The moment the eyes are open, these are the artifacts because of the eyes opening, and we'll have an artifact class also. You see the posterior rhythm has vanished, disappeared. So posterior rhythm, the alpha rhythm disappears by opening the eyes because you have become maybe attentive on the part. So when the visual attention is not there, you get the posterior dominant rhythm, the alpha rhythm on the part. But as I mentioned to you, if it is persisting when you are kind of like sleeping also, when your eyes are open also, that can be a part of alpha coma, because it should be reactive. Reactive means when the eyes are open, it should disappear. If it is still persisting, it can be abnormal and it can be a sign of gross brain damage on the part. Second is the beta rhythm. The name says it is more than 13 hertz, normally seen in drowsiness, especially disappears during the latter part of the sleep. And we see anteriorly, we have seen basically in different EEGs. These are the beta waves you see anteriorly. Posteriorly, you see more of an alpha waves, especially in the drowsiness or maybe in the wakefulness also. The beta waves, you see generalized beta, normally we see with the lot of drugs being given in those cases. Theta rhythm is less than 8 hertz, more than 4 hertz, seen in drowsy state and in sleep. And if it is found in the wakefulness, it may be abnormal on the part. So look at the theta waves, normally you find less than 8 hertz if you count in these parts. Delta is less than 4 hertz, and that also being seen, as you saw, in cases of sleep, or sometimes when you do the hyperventilation, you may see the slower waves because of the cerebral ischemia on the part, and you see these are the delta waves. You count 1, 2, 3, 4, 1 second, and you 4 waves. So normally you count the waves posteriorly, T6O2 on the part, especially if you're looking at other waves apart from the beta, because beta normally you see more anteriorly, like you see over here also on the part. This is a normal sleep, showing some amount of beta and a lot of delta waves posteriorly on the part. So you see theta waves when the amplitude, so even the frequency is less than 8, 1, 2, 3, 4, 5, 6, 7. These are the thetas, and then you got the delta waves when it is less than 4. 1, 2, 3, 4. So the similar one EEG page has got both theta waves and the delta waves in the location. So you identify the the EEG pattern. As I mentioned to you before, if you're seeing a delta pattern in a child who is awake, 8 years of the age, like you see in this child, that is abnormal. That suggests an encephalopathic state on the part. Sometimes you can get occipital delta, like you see in these cases, that also may be abnormal if it is in the awake state. Sometimes you can get the frontal delta, like in these ones, you see frontally delta waves that can also be abnormal and suggestive of some metabolic encephalopathies and those ones. Coming to the second part of the normal waveforms, we do the activation procedures. Commonly, we do the hyperventilation and photic stimulation. Hyperventilation we do for almost around 3 minutes. Normally, we don't do in children with the stroke or moya because that can give rise to the cerebral ischemia and you can precipitate further brain damage. It provokes absence seizure. We all have been taught about the absence seizure 3 spike and wave because of the hyperventilation. But what happens with the hyperventilation? Because of the decreased blood flow to the brain, you get the slowing of the waveforms, like what you see in the waveforms become slower and they have gone to the delta range, which is normal. Normally, hyperventilation technician writes about this is HVT starts and HVT stops. You get it by that part. Photic stimulation is also done in our normal routine lab, and this is from the 3 to almost around 30 hertz. What you get with the photic stimulation is that you get a response in the occipital cortex because of the photic stimulation. You get the photic driving when you get the similar kind of occipital waves as the photic stimulation, the frequency, or you can have the photopraxinal response also, where you get an effect from the activity in the part, or you can have the photoconvulsive response also, when you can get the true seizures with the photic stimulation. Normally, these are the cases where we see in generalized epilepsy, which are photosensitive. So like this is photic stimulation. You're giving the photic 5 hertz and you're finding the 5 hertz response in the occipit 1, 2, 3, 4, 5. So you give the 5 hertz photic and you get the 5 hertz response. You give the 8 hertz, you get the 8 hertz response in the occipit. This is photic driving on the part. And if it is a photoparoxysmal response, when with the response, when the photic stimulation, you get a generalized epileptiform activity, and that is suggestive of photosensitive epilepsy on that part. Now coming to the second part about our sleep state, you get the three things: vortex wave, spindles, and K complexes. Vortex waves are sharply contoured waves which are present at the vortex, that is the seizure location, and they may extend anteriorly, but normally they are seen in the stage 1 of the sleep part. Look at these waves. So for the vortex wave, you have to look at the central location, frontocentral, C4, P4. Then similarly at the C3, P3, in these locations, you get the sharply contoured waves. So these are typical of the vortex waves. You don't see much anteriorly or much posteriorly these waves. At times they can be seen in the runs, but the idea to pick them up is that they are still more prominent over the central location, and you get in the stage 1 of the sleep on the part. After the vortex, you get in stage 2 is the spindles. So they, as the name says, they are like spindle-like activity of 11 to 16 hertz, and they're also seen over the central location on the part. These are the spindle life waves. We'll see a couple of more slides of those ones. So they are like almost around 13 to 14 hertz waves, and they are more seen over the central location, C4, C, and C3, P3, those locations, the spindle waves. So they are the normal waves of sleep. Third is the K complex. K complex is a biphagic or triphagic sharp waves. We saw about the wave morphology in the beginning, which are followed by a sleep spindles, and they're also seen in the sleep only. So what you see, a biphagic or triphagic waves. So waves going up, down, and then coming up, and then maybe followed by the spindles. So waves, high amplitude waves going up, down, and then followed by the spindles part. These are the K complexes. They're also a feature of a normal sleep pattern where you find. These are like a K complexes, waves going up, down, and then up again. So these are classical of sleep, characteristics of waveforms in the part. So these are the spindles, as you saw, like spinning activity, and these are the K complexes. So these are the K complexes. The more you see these EEGs in the sleep EEG, I mean to say, the more you get accumulated with these kinds of complexes, basically. Drowsiness, I will just escape because they are not so seen routinely in the part. So what you see, recapitulation: awake, eye closed, you should get basically posterior rhythm present, eyes opening, low voltage, and you start losing of your posterior rhythm. If it is stage 1 sleep, you get the vortex wave. It is stage 2 sleep, it is spindles, and if it is or you can get the K complexes. Fine. So that is the part. So just to recollect, we are seeing the wakefulness. You see the posterior dominant rhythm. I'll take a couple of minutes more. So a posterior dominant rhythm. So it means like an 8-year-old child. You see alpha waves, 1, 2, 3, 4, 5, 6, 7, 8. This is wakefulness characteristic. Until you may see the beta waves. If you're seeing with the eyes open, eyes closed, the moment your eyes open, you lose the alpha waves. That is the characteristic of a posterior dominant rhythm. In the wakefulness part, drowsiness, you see less amount of alpha, you see more of a theta waves in those cases. Drowsiness, at times vortex may start appearing in those cases. Stage 2, you get vortex and the spindles and the K complexes. If you get arousal from the sleep, you get lot of muscle and the movement artifacts on the part. So what is the summary? Wakefulness again, posterior rhythm, anterior posterior gradient, sleep, vortex wave, K complexes, sleep spindles. So this is the part: wakefulness, posterior rhythm, which is reactive to the eye opening, and in the sleep you get the vortex, spindles, and K complexes. In brief, these are things which you have to remember. So understanding EEG, we talked in the beginning, we need to look at the age, because age dependent things are there. A state, we just now saw, sleep has got different features, awake has got different features. How is the background, and what do you find in the photic stimulation and in the hyperventilation on the part? Abnormalities can be because of the background or because of any discharges. Dr. Chandrakanta will be talking about those parts on the part. So how to read an EEG? Last couple of slides. Definitely look at the montages, the anterior posterior montage. Bipolar is most commonly we see for any artifacts. We have got different class for that. Organization, you look, how is the waveforms? We talked about the mental picture and then the landscape. Look at the general background. How do you see beta in the front and alpha in the back? Basically, any asymmetry between left and right hemisphere. Look for any focal glaring abnormalities on the EEG part. And when you start reporting, you report in these matters. What are the patient details, his age, and the name, and all those things, and then state the sleep, awake, sedated versus non-sedated, because once you get some medicines, it may give a generalized beta also. Some medicines may give. Activation procedure were done or not. A lot of children may not be cooperative for the hyperventilation, especially the young children, whether you have done it or not. What are the background rhythm? Background means what is the posterior dominant rhythm kind of thing. What is the most obvious rhythm in the child? If a child is awake and you're getting all theta, that could be an abnormal thing. Sleep features, hyperventilation, or any abnormality. So you light in these fields. EEG techniques, the background, the features, the hyperventilation, photic inflammation, what are the abnormalities, and what is the summary, and what is your impression on the part. Normally we write like technique, this is routine, awake, EEGs from electrodes placed according to the 10-20 system, findings, wakefulness, background activities continuous, anterior posterior gradient is there, posterior dominant rhythm is 8 to 10 hertz, reactive to eye opening, hyperventilation was normal, photic was normal, there were no abnormalities seen. The sleep features were present in the form of vertex wave, K complexes, and spindles. This is a normal EEG, and this is a normal impression on the part. Look at this EEG small graph. You can look at this part. This is 1 second, 1 second. You can see maybe a couple of vertex waves here, because these are the waves, and the fundamental location in this part. And you get the report and the impression in that sense. So that we'll discuss about the part. So normal EEG, background rhythm, you have to talk about the age, the state, sleep, awake. This is symmetrical, both sides, synchronous, both sides. Wakefulness, sleep, arousal. Normally, because in children it becomes difficult to pick up the arousal part, and maybe sometimes the drowsiness part also. And then hyperventilation and photic stimulation on the part. So this is about the normal EEG. I think we're just within time. And then we'll have the second part as an abnormal EEG.
Yeah, thank you, Dr. Praveen. In fact, this was very excellent presentation, clearing all doubts and going with in so slow pace just to act for better understanding by all delegates. And the best part was your reporting. So we are just in time, but I would like to tell all the delegates that all will be given a chance in our offline part, that you all will be given different EEG reports, and you have to make the report out of that. डॉक्टर अमित, अभी भी कोई कंफ्यूजन है आपको रिपोर्टिंग के संबंध में? बेसिक चीजें वही हैं कि आपको क्या देखना है। जो सबसे पहले तो ये कि जो सोच के रखा है, एक रिकॉर्डिंग सेटिंग जो बताया, मैं जस्ट डॉक्टर प्रवीण, आई एम जस्ट गेटिंग दिस लिबर्टी टू रिपीट फ्यू ऑफ द पॉइंट्स बाय यू। सेटिंग क्या, कौन सा सिस्टम है, 10-20 सिस्टम ऑफ इलेक्ट्रोड प्लेसमेंट, अवेक है या स्लीप ईजी है, या अगर स्लीप है तो इंड्यूस्ड स्लीप है कि नेचुरल स्लीप है, इंड्यूस्ड है तो कौन सा ड्रग दिया है, कितनी डोज में, वो भी लिखना है आपको, और उसके फ्रीक्वेंसी कितनी है, एम्पलीट्यूड कितना, जो आपकी सेंसिटिविटी आपने क्या रखी है वो रखना है। देन बैकग्राउंड फर्स्ट लाइन जो है आपकी कि कौन सी बैकग्राउंड है, डोमिनेंट है तो यूजुअली ये पोस्टीरियर डोमिनेंट रिदम होता है, वो आपको बैकग्राउंड रिदम पे ध्यान देना है। बैकग्राउंड रिदम इज सिंपली लाइक कि युद्ध के मैदान में घुसे तो माहौल कैसा है, तो वो बैकग्राउंड रिदम एक तरह का माहौल है जो बताता है कि हाँ ये जो है बैकग्राउंड में हमारा ये चल रहा है जो चल रहा है। देन अगर वो स्लीप रिकॉर्ड है तो स्लीप रिकॉर्ड में जैसा बताया, आई आर्टिफैक्ट्स पे बहुत ज्यादा होते हैं, उसके बारे में एक अलग से टॉक है। और आर्टिफैक्ट सबसे ज्यादा कंफ्यूज लोगों को करते हैं, खास करके बिगिनर्स में तो बहुत ज्यादा कंफ्यूज करते हैं। सीजर्स वर्सेस के स्पेंडल, इसके बारे में डॉक्टर प्रवीण ने बताया, इसको और एलिबोरेट करेंगे वो। जैसे के स्पेंडल्स या वर्टेक्स वेव, ये अगर आप बहुत सरसरी तौर पे देखेंगे तो आप धोखा भी खा सकते हैं, तो इसको पहचानना जरूरी है कि आई मूवमेंट आर्टिफैक्ट और आपके स्पिंडल वेव स्लीप स्पिंडल्स एंड के कॉम्प्लेक्सेस, ये सारी चीजों को हम लोग समझें कि क्या सीजर है नहीं है, देन वी लुक फॉर एनी एबनॉर्मल। तो एबनॉर्मलिटीज बहुत ज्यादा नहीं होती हैं, बेसिकली वो 4-5 चीजें ही होती हैं, स्पाइक एंड वेव, शार्प वेव, फेज रिवर्सल। यूजुअली मोस्ट लाइकली इन चारों में से कोई एक चीज होती है, या अनएक्सपेक्टेड स्लोइंग अगर है तो वो फोकस के हिसाब से। सो अगर कहीं फोकल स्लोइंग है तो दैट इज इम्पोर्टेंट फॉर सम एस्पेक्ट। एंड थैंक यू वंस अगेन डॉक्टर प्रवीण फॉर योर एक्सेलेंट प्रेजेंटेशन। आप इन कुछ के स्पेंडल के बारे में, मुझे लग रहा था के कॉम्प्लेक्स के बारे में कुछ और बताते।
Maybe because we have a talk of the abnormal waveforms, so I thought and see these K complexes, you rightly said, K complexes, vortex waves, and spindles, they are very easily confused with the abnormalities on the EEG. That is the one thing. Second thing, so you have to be, I mean, the best part to understand is this: any abnormalities on the EEG has got a field. नॉर्मली जो ब्रेन में कोई डिस्चार्जेस कहीं से निकलता है इट इज, तो वो वहीं पे नहीं रुकता है, वो उसका एक स्प्रेड होता है, वो एंटीरियरली पोस्टीरियरली स्प्रेड होगा। फिर वो तो जो पहला चीज हमें देखना होता है कि जो हमारा वर्टेक्स वेब है वो सेंटर लोकेशन पे होता है, CZ पे होगा, F3C3 F4C4 पे होगा। यूजुअली वो एंटीरियरली या पोस्टीरियरली उसका पार्ट नहीं होता है। फिर वो उसका जो फेज रिवर्सल होता है वो CZ पे होता है, उसकी मॉर्फोलॉजी भी मोर ऑफ ए शार्प वेव होती है, उसमें स्प्रेड नहीं होता है और वो रिपीट करता है। फिर वो तो कोई अगर एबनॉर्मलिटीज निकल के आती है वहां से तो आप देखेंगे कि वो आगे की तरफ स्प्रेड होगी, एंटीरियरली जाएगी, फ्रंटोटेम्पोरल में जाएगी या ऑक्सीपिटल में जाएगी, जो हमारे सिग्निफिकेंट स्पाइक वेव्स होते हैं। Similarly, spindles are easy to pick up because they have the sinusoidal morphology, जो उसका गोला सा मॉर्फोलॉजी होता है इसका स्पिंडल्स का, तो उसमें नॉर्मली हमारे स्पाइक्स वाली मॉर्फोलॉजी होती नहीं है, और इनका जो फ्रीक्वेंसी भी होता है वो 12 to 13 हर्ट्ज के आसपास का होता है। स्पिंडल्स को हम आसानी से पिकअप कर लेते हैं और वो भी सिर्फ उसमें ही होता है। रही के कॉम्प्लेक्सेस की, तो वो थोड़ा कभी कभी डिफिकल्ट होता है बिकॉज समटाइम्स इफ यू डोंट लुक एट क्लियरली दे आर मोर डिफ्यूज इन नेचर, because they start from anterior and they run towards the posterior part, के कॉम्प्लेक्सेस का पार्ट। लेकिन उसका जो के कॉम्प्लेक्सेस का ट्रिक है कि मोस्टली दैट कम्स अलोंग विद द स्पिंडल्स। तो एक ऐसा वेव जो एंटेरियर से पोस्टेरियरली में हो, शार्प कंटूर में हो, लेकिन उसके साथ में स्पिंडल हो, चांसेस ज्यादा है वो के कॉम्प्लेक्स के साथ में होगा। और उसकी जो मॉर्फोलॉजी होती है दैट स्लाइटली ऑन द वाइडर साइड, वो वाइड होता है, आपने देखा होगा कि वो जो उसकी विड्थ है दैट इज स्लाइटली ऑन द वाइडर साइड एज कंपेयर टू व्हाट नॉर्मली वी सी in the spikes or even in the normal shafts what we see, and that is followed by the spindles, and most often they are sleep features, they only come in the sleep part। normally जो हमारे discharges होते हैं हम उसको देखते हैं कि इंटरइक्टली वो अवेकफुलनेस में भी तो नहीं आ रही है, तो these things helps us in making our this is a normal sleep or this is something which is abnormal। so this is like your visual impression, the number of times you see you start picking them on the part।
Thank you, Dr. Praveen. I want to just tell all the delegates कि मैं देख रहा हूँ चैट बॉक्स में बहुत ज्यादा कमेंट्स नहीं आ रहे हैं, तो एंड आई एम वेरी मच श्योर कि इतना आसान कोर्स भी नहीं है कि मन में डाउट्स ना आए। तो अगर आप चैट बॉक्स को जिंदा रखेंगे, मन के डाउट्स को क्लियर करते रहेंगे, तो आपको जो है ना इंटरेस्ट लगता रहेगा, फिर आप उसमें और इन्वॉल्व होंगे। इट इज नॉट सिंपल लेक्चर वे मेथड। अगर लेक्चर के तौर पे सुनते रहेंगे तो फिर शायद वो मकसद आपका पूरा नहीं होगा। तो लाइक डॉक्टर अमित रस्तोगी, आप अपना कमेंट करते रहे, कुछ कमेंट करते रहे, अच्छा लगे तो भी, खराब लगे तो भी, उससे एक माहौल बना रहता है। एंड नाउ आई रिक्वेस्ट आवर सेकंड स्पीकर ऑफ टुडेज सेशन, डॉक्टर प्रोफेसर चंद्रकांता। Dr. Professor Chandrakanta, she is a professor of pediatrics in KGMU, Lucknow University, and she has got a special interest in pediatric neurology, and she is already doing pediatric neurology for a couple of years. So, Dr. Chandrakanta, madam, please start your session. You can share your screen.
So, thank you, Dr. Ajay. And we sincere thanks to AOP UP, Dr. Ajay, Dr. Praveen for giving me this opportunity. And I'm happy to see Dr. Rashmi Kumar, who told me about the alpha, beta, delta of EEG. So should I share my screen?
Yeah.
So is my screen visible?
Yes, yes.
And I'm audible?
Yeah.
So Dr. Praveen has taken a very nice lecture and have told you about the normal EEG. And I will be talking about the abnormal EEG. So knowing the normal waves, normal EEG is very important because most of the time there is no problem in identifying the suspicious area on EEG. But the problem is that whether that suspicious area is abnormal or normal. So knowing normal is more important, and we will now discuss about the abnormal EEG waves. So the objective is the identification of abnormal EEG waves, and I will just cover the common things. So EEG abnormality, they can be focal and generalized. Okay, so focal means that the findings are restricted to the particular area of the brain, and generalized when the findings are generalized. Generalized means that they are present on both the sides of the hemisphere, left and right, and from anterior to posterior part. Okay, so first start with the focal EEG abnormalities. So the focal EEG abnormalities can be either in the form of background abnormalities, or they can be focal epileptiform discharges. And there are some particular patterns of focal abnormalities we will discuss. And we will learn how to localize the focal abnormalities, and there can be focal ictal discharges. So mostly what we see in EEG is the interictal discharges. So the child don't have convulsion at that time. But if the child is convulsing during the recording, it's called ictal recording. So what can be the focal background abnormalities? So background abnormalities can be in the form of amplitude asymmetry, background asynchrony, alpha asymmetry, or focal delta slowing, and there can be some abnormalities found during hyperventilation. So Dr. Praveen has already discussed how to measure the voltage of a wave. So amplitude asymmetry means that there is difference in the amplitude of the waves between the two hemispheres. So if there is a gross damage to the one side of the brain, then on that side we will get low voltage activity. Like there is hemiatrophy on one side of the brain, we will get low voltage activity on that side. So in this EEG you can see, so this is the left side of the cerebral hemisphere, odd number F73, and they have normal voltage. And if you see the right side of the cerebral hemisphere, you see that the voltage of the wave is low. Amplitude is low in comparison to the left side, and this difference should be more than 25%. If it is less than 25%, that is normal. And sometimes this asymmetry may not be obvious during the recording, but it becomes obvious during the hyperventilation. So we look for the amplitude, and there may be asymmetry of the alpha waves also. So in this, you can see from previous that the other waves, they have almost the equal amplitude on both the sides. But if you just focus on the alpha rhythm, alpha we know now that we see in occipital area. So this is left occipital and this is right occipital area. So you can see the difference in the amplitude of the alpha waves. So this is alpha asymmetry and can be found like some lesion in the occipital area. So there can be alpha asymmetry. And then background abnormalities can be in form of asynchrony. Synchronous background means that both the sides have almost similar type of waves, the left and the right. Okay. But if you see in this picture, okay, so this is the left side and we see that there is a spindle over here. Okay. But there is no simultaneous spindle on right side. Okay. And similarly here spindle is seen on right side and not on the left side. So they are not coming simultaneously. So this is asynchrony between the two sides. And this asynchronous sleep spindle, this can be normal in infants and can be abnormal in older children. So the normal background should be synchronous and there should be no asymmetry. And the waves should be what we expect according to the age of the child and according to the state, whether the child is awake, sleep, light sleep, or deep sleep. Then the abnormality, the background abnormality can be in form of slowing of the wave. So this is showing you the focal slow delta waves. So if you see here, in comparison to the rest of the part of the EEG, so here waves are faster, they are not so high amplitude. Here it is delta frequency range. So we are getting the focal delta slowing that can be due to some structural cause in that region. So abnormality doesn't always mean the epileptiform discharges. There's so many abnormalities possible in EEG. So, and the abnormality can be in the form of epileptiform discharges. And now we are aware about the terms spike and sharp and polyspike. Okay. So what is a spike and what is sharp? Okay. So these terms we will listen again and again. Okay. So in EEG, if you see, there are two types of vertical lines. Okay. So this is dark lines and in between there are faint lines. Okay, so this is 1 second and this area, one small area, this is equivalent to 200 millisecond. So the duration of the wave decides whether it is a spike or a sharp. So spike is shorter wave and the duration is less than 70 millisecond and some books write less than 80. Sharp is relatively broader waves and the duration is between 70 to 200 millisecond. But practically when we see, we hardly calculate it whether it is spike or sharp. The appearance is also important. So it is said that if a wave is looking, the tip looking like if it is going to hurt you, it is a spike. Okay. So spike has a nature like it looks like a spike. Okay. And these spike and sharp, they are often followed by the slow wave. So pattern, epileptiform pattern can be a spike wave pattern like this, spike followed by a slow high voltage wave, or it can be a sharp and wave complex, or the other variety may be a polyspike wave pattern. Okay, so here you see there is only one spike and it is followed by the wave. Here you see there are multiple spikes, and this is followed by a wave, distorted high voltage wave. So this is polyspike and wave pattern, and this pattern we often get in myoclonic type of epilepsies. So what are the characteristics of epileptiform discharges which will help us that it is not an artifact or this is not an normal thing? So most of the epileptiform discharges, they stands out from the background. What it means? That you don't need to try to find out the spike and wave. It is obvious. Okay, so it stands out from the background. There is negative phase due to paroxysmal depolarization. I will show you. And there is after coming wave due to hyperpolarization. And they have electrical field. And on bipolar montage, they show phase reversal. So what is electrical field? So you must have seen when we throw a stone in the water. So the waves are formed and the amplitude of the wave will be maximum at that point where we have thrown the stone. And then there are slower waves towards the periphery. Okay? So the abnormality doesn't restrict to a particular area, it has a field. So surrounding area to that particular electrode will also show abnormality. If only a single electrode is showing abnormality, it's most likely a artifact, not a true epileptiform discharge. So like in this picture, in this EEG, you can see that there are spikes and wave. These are the abnormal spike wave discharges. So they have maximum amplitude at frontal area. Okay, and this is right frontal. Even number is right. Okay, so right frontal region, the amplitude is maximum, but it's not restricted to the frontal area. The other part is also showing a field. There is slight, small spike wave pattern in the other part also. So in monopolar montage, monopolar means that we are recording the electrical activity of one electrode in reference with the referential electrode. So in monopolar montage, the abnormal area will show the maximum amplitude and the remaining will show the smaller amplitude of abnormal waves. So in this EEG, we can see probably it is the right frontal area which is causing problem. In bipolar montage, the epileptiform discharges, they show phase reversal. Okay. What is phase reversal? Phase reversal means when we are recording the activity between the two electrodes. When we go towards the negative area, we get a negative deflection. So there in this phase reversal, you can see that one spike is coming down, the other spike is going up. Okay. So during depolarization, in negative electric field is generated. When the epileptiform discharges, they are generating, there is depolarization of the area and this is a negative field. So this phase reversal will points towards the negative area. So here we are getting a phase reversal at C3. So likely that epileptiform discharge is originating from the C3. This is again showing a phase reversal. So if you see in this, one spike is coming down, the other is going up, and here is showing a phase reversal. Okay. So in this likely electrode near to the epileptiform discharge, it is F7. . So to summarize, the epileptiform discharges, they have a field, they show phase reversal on bipolar montage. There is first negative wave. So in EEG, negative wave means that it is going up and it is followed by a slow wave. Okay? And this slow wave, this spike is due to depolarization of the area, and after that there is hyperpolarization of that area, which causes a slow wave. So spike followed by a slow wave. So we can see that focal abnormalities can be epileptiform, non-epileptiform, and there are some special type of pattern. Dr. Praveen has already discussed that they can be intermittent rhythmic delta activity. So in this you can see there is rhythmic delta activity in the frontal area, and depending on the location we call them, there are different names. Okay, so like if it is in frontal area, it is FIRDA, FIRDA, FIRDA. If it is in occipital area, this is ORIDA. Okay, and if it is in temporal area, TIDA. Okay, so intermittent rhythmic delta activity we can found in cases of encephalopathy. Then there can be periodic lateralized discharges. Okay? And you must have heard this name in herpes encephalitis. Okay, so what is periodic? Periodic means that your spike wave or the abnormality is coming at a regular interval. And what is lateralized? That it is lateralized to one side. So periodic epileptiform discharges lateralized, often we get in herpes encephalitis, but we can get in other conditions also. So these were the focal abnormalities. Now the generalized EEG abnormalities. They can again be a background abnormality, or they can be generalized epileptiform discharges. They can be some spatial pattern pointing towards a specific epilepsy syndrome, and they can be ictal discharges, generalized. So background abnormalities can be low amplitude EEG. There can be generalized slowing or generalized fast activity of the waves. Can be hips arrhythmia or bus suppression pattern. So what is low amplitude EEG? So in normal EEG, you see the waves coming. In this EEG, you hardly see any waves. It is looking like a straight line. So low amplitude EEG, when the voltage is less than 20 microvolt, we call it as low voltage EEG. And this can be seen like in cases of severe birth asphyxia and indicates a poor prognosis. And then there can be generalized slowing of the EEG. So focal slowing we get mostly in focal pathology of the brain. Generalized slowing we get in like cases of encephalopathy. But before saying that there is slowing of the EEG, we should know the child's age and whether the child is sleeping. Okay, like this EEG. This EEG is showing the delta waves. So delta waves for awake EEG, that is abnormal. It is a slow wave. It indicates that there is some problem. But if it is a sleep EEG, N2 or N3 stage, then this EEG is perfectly normal because we get delta in sleep. So before commenting that it is slowing, you need to confirm whether the child is sleeping or the child is awake. Then the generalized abnormality background can be in form of fast beta activity. Okay? So in this EEG, you can say all over the EEG, this is showing a fast beta activity. And this can be found like in cases of certain drugs like diazepam, we have used for sedation, or generalized fast beta activity can be there. Then we all are aware about the hips arrhythmia. And what is hypsrhythmia? It is a total disruption of the background. You hardly see any background rhythm or a baseline. The waves are going up and down. They are slow delta waves, high voltage, chaotic background, and there are spike wave discharges in between, and the poly spike wave discharges are there. And there can be bus suppression pattern. So bus suppression pattern is very easy to recognize. There are areas of the bus which shows the high voltage burst of spike wave discharges or other waves, and this burst is followed by the suppression of the background, and the line looks almost straight. So this is bus suppression background. You can get in like Uttar syndrome or early myoclonic epilepsies, sometimes in West also. So generalized abnormalities can be in the form of background abnormalities, or they can be generalized epileptiform discharges. So what are the types of generalized epileptiform discharges? Can be spike wave pattern, polyspike wave pattern, 3 Hz spike wave pattern, and photoparoxysmal response. So this is showing a generalized spike and wave discharges, and if you notice that in between, like this is a spike and this is wave. Okay. This is left side and this is right side. So generalized means abnormality left and right and from anterior to posterior. Okay. So this is generalized spike and wave discharges. Then there can be generalized polyspike wave discharges. Often we get in myoclonic epilepsies like juvenile myoclonic epilepsy. So there are multiple spikes followed by the wave, and it is generalized. And 3 Hz spike and wave pattern, which we typically see in absence epilepsy, and looks very beautiful. Okay, so what is 3 Hz spike wave pattern? We already know how to count the frequency. So this is 1 second. And now if you count how many spike and wave in 1 second, 1, 2, and 3. Okay, so this is 3 Hz spike and wave pattern generalized, which is found in absence epilepsy. And this can be precipitated by the hyperventilation. So in typical absence epilepsy, there is normal background in this sudden appearance of generalized 3 Hz spike wave discharges. And then the abnormality can be in the form of photoparoxysmal response. So what is photoparoxysmal response? We know that we use hyperventilation and photic stimulation to precipitate the epileptiform discharges. And how to know that the photic stimulation is going on? Photoparoxysmal response means that when we are giving photic stimulation, there is precipitation of the epileptiform discharges, and often we get in myoclonic epilepsies. And if a child has photosensitivity like this, we have to avoid flickering light and those type of thing, because that can precipitate epilepsy. So how to recognize that photic stimulation is going on? There is always one indicator either above or below the EEG, indicating that its photic stimulation is going on, and during photic stimulation there are generalized epileptiform discharges. And this should be not confused with the photic drive response. What is photic drive response? Is a normal response to photic stimulation. Dr. Praveen has already told that the frequency of the photic stimulation will match the suspicious area or suspicious spike. So the frequency is same. It starts with photic stimulation and ends abruptly at the end of the photic stimulation. So this is a normal response. This is not spike and wave discharges. This is photic drive response. Then there can be generalized periodic epileptiform discharges. So to know the periodicity, you have to look many pages. If you are just looking on one page, it's difficult to decide that it is periodic. If you know, if you see many pages, then you will notice that it is occurring almost after same duration. Okay, and this is showing actually the R complexes, sharp and slow wave complexes, periodic, which we found in cases of SSP. Then the epileptiform discharge can also be in form of fast beta activity, the paroxysmal fast beta activity or beta burst. So this is different from the generalized beta activity background. जो हमने पहले देखी थी, that was all over the record was beta. But here if you see, there is sudden burst of the generalized beta activity and this high voltage. So this is also epileptiform type of epileptiform discharge. Often we get in cases of Lennox-Gastaut syndrome. And there can be slow spike wave discharges in cases of LGS. So in this picture, if you count, the frequency is 2 Hz. In LGS, we get slow spike wave discharges of 1.5 to 2.5 Hz. So then ictal EEG when we are recording the activity during the seizure. So according to the type of seizure, we get different types of ictal recording. So Dr. Ajay, only 3-4 slides are left.
Please carry on, please.
So this is ictal recording of infantile spasm. So in infantile spasm, when we are recording EEG during spasm, this will show electrodecremental response. So what is that? So here is the area where the child had spasm, and before that this EEG was abnormal. So at the time of spasm, this abnormal EEG activity, high voltage, disappeared. There is a distorted wave superimposed by the beta. So this is called electrodecremental response of infantile spasm. In myoclonic seizure, we get polyspike and wave pattern. So you can see polyspike and wave pattern. If it is case of generalized tonic seizure, we often get the fast high voltage beta activity like this. Case of generalized tonic-clonic seizure, at the onset of seizure, during tonic phase, we have spikes, frequent spikes. During clonic phase, it is relatively so, we get spike wave pattern, and after the seizure is over, the background don't return normal immediately. There is some depression of the background or other background changes for some time. So this is showing it generalized tonic-clonic seizure. So with the start of the seizure, there is multiple spikes, and then during clonic phase, it slows down, spike wave pattern, and when there is end of seizure, there is background suppression, and later on it becomes to normal. Okay, so I end my presentation here. So we have learned about the types of abnormalities, focal and generalized epileptiform and non-epileptiform. If you have any query, you may please ask. Thank you.
Thank you, Dr. Chandrakanta ma'am. You actually all delegates to note that as many EEG you want to observe, ये पिक्चर तभी क्लियर होती है. एक्चुअली ये जो आपको जो एबनॉर्मलिटी दिखाई जा रही है, ये एक पेज में दिखाई जा रही है, जबकि EEG जो सामने आता है वो आपके पास 100, 150, 200 पेज की EEG होती है, और उसमें भी अलग अलग मोन्टाज होते हैं. तो
कोई देता नहीं है. Usually we have a digital thing. But if you are aware, like sometimes in one page, it's very difficult to decide that it is normal or abnormal. So we go for a soft
तो हम लोग डॉक्टर चंद्रकांता जी, हम लोग ऑफलाइन है, ऑफलाइन जब करेंगे ना तो फिर पूरा के पूरे तब हम लोग इसके क्विज करेंगे कि इसमें आपने पूरा का पूरा सिलसिले में 100 पेज में कहाँ नॉर्मलिटी देखा और उसको पकड़ना है। तो वो अच्छा, वैसे बहुत बढ़िया इसमें सारी चीजें। एक दो वर्ड अगर आप इसमें बताएं पेनाइटोपोलस सिंड्रोम के बारे में, वो एक इम्पोर्टेंट पॉइंट आई थिंक
मैंने टच नहीं किया, बिकॉज़ देयर इज अ सेपरेट लेक्चर अबाउट द focal and generalized epilepsy.
डेफिनेटली
So I thought
डेफिनेटली
that
एंड
particular epilepsy में कौन सी finding होती है, that will be covered in that. But penetrance is shows the it is like a occipital epilepsy.
ऑक्सीपिटल एपिलेप्सी एंड फोटिक स्टिमुलेशन में वो आता है, वो है ना। बहुत बढ़िया मैडम, थैंक यू वेरी मच।
Occipital area will show epileptiform discharges and the child will present with autonomic manifestation and the seizures.
डॉक्टर रश्मि कुमार मैम है कि आई कैन नॉट सी। मैम को मैम रिक्वेस्ट कर रहा हूँ आपसे, प्लीज मैम कुछ कमेंट करें और कुछ अपने अपने एक्सपीरियंसेस शेयर करें।
मैम की क्लिनिक होती है शाम को, हो सकता है पेशेंट भी तो नहीं बिजी हो गए।
हाँ हो सकता है, कोई बात नहीं, ठीक है, हम उनसे पहले से बता के रखेंगे। सो आज का हमारा सेशन कंप्लीट हो रहा है, तो हम लोग आज दो लेक्चर सुने और कल बहुत ही बढ़िया कल आपको रियल वीडियोस के साथ में ये चीज मिलने वाली है। और डॉक्टर अनूप वर्मा का कल लेक्चर है, और जो ईईजी में आर्टिफैक्ट्स की बात होती है कि इनफैक्ट ईईजी में जितनी प्रॉपर फाइंडिंग होती है, लगभग यूजुअली आर्टिफैक्ट्स बहुत ज्यादा परेशान करते हैं, तो उसके बारे में हम लोग कल चर्चा करेंगे। और तब तक के लिए सबको बाय बाय, थैंक यू वेरी मच फॉर